Welcome everyone to the Lymphie Strong YouTube channel. And today I have a very special guest and dear friend of mine. It's Dr. Chen from the Cleveland Clinic Center for Lymphedema Research, and I have to cheat for the full name, and Reconstructive Surgery. He is a professor and the co-director of that center. As announced on World Lymphedema Day 2021, we officially had, through Dr. Chen's courageous efforts, established the Center for Lymphedema Research to be a resource for the Lymphie Strong community. If you're not familiar with the Lymphie Strong community, we are a global patient support and advocacy group. We started with a small Facebook group back in 2015, and it's largely based in the United States, but we've also grown worldwide. Today's session is strictly a Q&A. If you're interested in visiting the links associated with Dr. Chen and the Cleveland Clinic, you can find them on lymphiestrong.com/Cleveland Clinic. You can also join our Facebook group, where Dr. Chen is a very active member and participant with our support questions. The name of that group on Facebook is the official Lymphie Strong Inspiration Group for Lymphedema. So without further ado, we're going to dive right into the Q&A session. For those of you who have joined us live, we ask that you post your questions in the Q&A so that we can address them efficiently and not in the chat. Reserve the chat comments just for general commentary. Thanks. And without further ado, Dr. Chen.
Thank you, Vern, for the introduction. And I appreciate this opportunity to be able to directly address your questions. Not too long ago, during the pandemic, we were temporarily allowed to directly help people from across the country with virtual visit. But now, as the COVID situation improved, that temporary relaxation of our policy has been lifted. So now we can't offer virtual visit. That means our ability to help people who are remote from us is now again limited. So this is our way to try to provide medical, well, some of the knowledge that's not as frequently disseminated unless you go and see a lymphedema specialist. And hopefully we can share those information with you and help you. I also have with me Erica Hopkins, who's been helping me and taking care of lymphedema patient population. Okay, well, we can get started with your questions.
So first question is, those of us with, so let me start by saying that to protect patient privacy and confidentiality, I will not mention anyone's name in these recordings so that your name remains anonymous. So those of us with leg LE are frequently told arm LE surgeries tend to have better outcomes. Do you see this changing over the next few years in that leg surgeries catch up to outcome levels to that of arm surgeries?
Okay, so before I start responding to questions, I need to give the disclaimer that we're not supposed to, this is similar to when we perform a virtual consultation, we're not supposed to formally diagnose or dispense treatment recommendation, as we are not licensed in your state. So I'm going to try to keep the answers in my response fact-based and not individually tailored, and also keep in mind that there are different opinions in the field. So what I'm about to tell you represents my opinion. It certainly is not without basis. As you're probably aware, we are constantly engaging in rigorous investigations of lymphedema pathophysiology, and lymphedema treatments. So okay, so let's get to the question. So the statement, I would say, is partially true. in that lower extremity lymphedema tends to be more challenging to treat. But it doesn't mean that lower extremity lymphedema treatment outcomes are disappointing. In fact, I would say lower extremity lymphedema treatment outcomes are very favorable and quite encouraging by the fact that I have a hard time recalling a lower extremity lymphedema patient who following treatments are unhappy. So of course, the best possible treatment outcome is a thorough reversal of disease process, which means that the patient no longer has swelling and no longer requires any form of treatment. But if you think about modern medicine, the conditions that we treat today, there are very few conditions that we can thoroughly treat. We're not curing high blood pressure or diabetes or heart disease for the most parts. For these conditions, we manage. And patient can still have a favorable outcome and continue to live a productive life. Therefore, I would say upper extremity lymphedema in general does respond more to treatments, whether it is conservative treatment or with surgery, but it doesn't mean that lower extremity lymphedema cannot be treated to satisfaction. I think lower extremity lymphedema treatment outcomes are still, for the most part, very encouraging and satisfactory.
Okay. Next question is, do you foresee the possibility of a device being invented that could be implanted or worn to help with lymph movement, as a pacemaker does for the heart?
As of this time, no. Actually, there are devices that have come out. Essentially, they are portable pneumatic compression pump. But I think those devices are certainly promising. But before we start to tell everyone to go out there and purchase these pneumatic compression pump that are portable and you wear them all the time, there are more studies that need to be done on pneumatic compression. First of all, there isn't a consensus on pneumatic compression. I would say more of us would hypothesize that pneumatic compression pump is helpful, but there are still some experts believe that pneumatic compression pump can potentially be harmful. The jury is still out. We still don't know for sure yet. I think there are reasons to speculate that it's most likely helpful. But even if pneumatic compression is helpful, what type of setting? What is the best compression pressure? That's unknown. So before we start to talk about portable pump, there's still more work to do, more research to do.
Okay, the next question is, hi, I know this is a difficult question. I'm considering LVA, primary lymphedema in both legs, but left is worse. I'm mainly concerned about getting lymphedema in the harvest site. What are the percentages of the onset of lymphedema at the harvest site?
I think you're confusing the concepts a little bit. I think you're referring to the lymph node transfer. So yes, in lymph node transfer, we remove lymphatic tissue, including lymph nodes, from a part of the body, and we transfer it to the affected arm or leg. And there is certainly the concern of causing lymphedema at the donor site or harvest site. So our strategy, and that is my opinion, I need to be respectful to surgeons who hold different opinions. But in my opinion, patients with primary lymphedema should try to stay away from the transfer type procedures. And that would include both lymph node and lymph vessel, the more advanced lymph vessel transfers. Because whether we're transferring lymph nodes or lymph vessels, we're still harvesting lymphatic tissue from the part of the body to treat the affected part. And patients with primary lymphedema are particularly at risk for developing lymphedema at the donor site. So patient with primary lymphedema, our mainstay is LVA procedure, which is connecting lymph vessels to veins at the affected site. So in this case, it would be connecting lymph vessels to veins in the affected legs without cutting anywhere else in the body. So there would be no donor wound.
Gotcha. Okay, the next question is, I am 3 days post-op VOLT from Mayo Phoenix. Insurance is still pending approval due to experimental procedure and limited proof of success per the insurance. Insurance declined peer-to-peer with Mayo. Any suggestions would be helpful. My surgeon is proactively involved. Thank you.
So insurance is a major problem. It's a major problem for all of us who are committed and feel passionate about helping all of you lymphedema patients. So my suggestion is to talk to your surgeon about what you together can do between patient and surgeon. It is incorrect to say that the surgery is experimental. Lymph node transfer was initially performed in the 70s, and we're in 2021 now. So the procedure is not experimental. We do know quite a bit about the procedures. The efficacy of the procedure is well investigated. In the hands of experienced surgeons, lymph node transfer is not, at least the outcomes of lymph node transfer is not too uncertain. It's actually quite predictable. The reservation on lymph node transfer I have just mentioned is the donor site lymphedema, causing lymphedema at the donor site. That is the concern. So I think a potential strategy that you can try is to ask your surgeon or even yourself to search in the medical literature to find studies supporting your case. I'm sure you can find lots of studies on lymph node transfer. It's not a new procedure. It's been around for a while, and it's been quite extensively performed. And then submit those studies to the insurance. Don't give up, just keep trying.
I know I've done appeals on different things, and even when they said I could no longer appeal, I still appealed and I eventually won.
So you may feel
not to give up.
as a patient, you may feel that you may feel you don't have a lot of power or leverage when talking to the insurance company. So you may not have the medical knowledge. However, believe it or not, insurance company respond more to you than to us. You are paying them, not us. So from my experience, patients who are persistent tend to have much better chance of getting covered by the insurance carriers. So gather information and advocate for yourself, submit the information to the insurance carrier.
Next question is, I am a horseback rider with primary left leg lymphedema. Since leg pressure is used to ride a horse, is lymph vessel transfer a possible treatment?
So I don't think horseback riding is really a consideration here on the treatment planning on which procedure to perform. So the treatment options would be, first of all, well, I'm going to try to simplify it as much as possible without giving a lecture. The first step is to find out whether there's already lymphedema-induced lipodystrophy or lymphedema fat. If there's a lot of lymphedema fat, the objective of treatment would be to remove these lymphedema fat, because as far as we know, no amount of compression and no amount of reconstruction surgery, whether we do LVA, lymph node transfer, lymph vessel transfer, will remove the lymphedema fat. And the presence of lymphedema fat would make your compression ineffective. usually when lymphedema fat starts to develop, what the patient will see is they start to need to increase their compression pressure to achieve the same level of containment. And usually their compression ended up becoming inadequate. And then the inflammation continues. Then even worse, they develop now fibrotic lymphedema fat, which further worsen the efficacy of compression treatment. So it's a vicious cycle. Now they needed even more compression. They went to flatten it, they went to custom garment, and so on and so forth. So if there is already significant amount of lymphedema fat, the lymphedema fat needs to be removed, most frequently with liposuction. Liposuction, now this is quite important, our study, which is finally going to come out after almost 3 years of back and forth with the reviewers, is the finding that liposuction, and this is a good news for the patient, liposuction not only remove lymphedema fat, but also stimulate improvement in lymphatic drainage, which we have consistently observed on imaging studies following liposuction. So on the other hand, if the patient doesn't have significant amount of lymphedema fat, the patient is still having mostly a fluid predominant disease, then we focus on restoring the lymphatic drainage with either LVA, lymph vessel transfer, or lymph node transfer. So that's basically the treatment, the thought process on treatment planning and deciding what would be the most appropriate procedure for the patient.
I think you sort of answered the next question with that explanation. The next question is, so for primary lymphedema in the legs, typically the surgery is LVA?
Yes. Well, in primary lymphedema with fluid predominant disease, if a patient with primary lymphedema already has substantial amount of lymphedema-induced lipodystrophy, then the treatment of choice would be liposuction. Following liposuction, the patient may become a candidate for LVA or lymph vessel transfer, potentially lymph node transfer, although in my practice, I no longer perform lymph node transfer. Lymph vessel transfer, essentially, it's a less invasive procedure, has replaced lymph node transfer. So it would be in that sequence. But in general, yes, we do try to stay away from transfer procedure in patients with primary lymphedema.
Okay, so we're out of the open questions for now. I'd like to encourage everyone that is attending to submit at least one question. We're in a group that essentially submits questions 24/7, 365 days a year. Please do not be shy about asking any question under the sun of Dr. Chen and of course his fellow panelist, Erica. I'm gonna throw one out that I see all the time in my group. And just for full disclosure, transparency, Dr. Chen has never operated on me. I'm not a candidate for surgery at this time. And therefore, I can only give my opinion on things that I have personally experienced. A lot of people ask me my opinion on what surgery they should do. I cannot give that because I myself have never had surgery. Can't tell you what it's like or any of that is associated with that experience. But what I do see is very common questions that come across the group. And a top one is, do you have to be under a certain BMI? Why is it important to be at a certain weight? And from my experience in other surgeries, that's because of the anesthesiology. They want your heart to function under anesthesia, but I'd like your opinion or you to speak to why weight is so important during surgery.
I'm glad that you mentioned this question. This question is incredibly important, and this is a great opportunity to address that. Erica, would you want to take that?
Sure. Can everyone hear me okay?
Yes.
Yeah, so Essentially, in our practice, we have a couple factors that we consider to make sure that a patient is a safe candidate for surgery. And before they even proceed with a diagnostic test to see which surgery would be the most applicable to them. But for the BMI specifically, and also for Dr. Chen's practice, we're currently limiting it to a 32 BMI or less. And part of the reasoning behind this is because it's a protective factor, if you will. We want to essentially protect our patients from some of the post-operative complications that can manifest and are related to elevated BMIs based on previous studies. And some of the more common ones that we educate our patients on are things like infections, seromas, wound dehiscence, and it's all very applicable as well to the type of lymphatic surgeries that we essentially provide to the patients, or which ones they are good candidates for. So in a way, we've seen sometimes with other referrals of how these elevated BMIs have put patients in compromised post-operative situations that are not ideal. So part of the discussion that we have with them is essentially to discuss this and to educate them on why we essentially have this standard, and it's a protective value again because of these post-operative complications.
Let me supplement Erica's answer. So the reason behind the BMI cutoff is, well, when we operate, number one consideration is safety. Number two consideration is we want the surgery to work. A surgery that doesn't work is organized trauma to the patient, and it's hurting the patient. So these two criteria need to be met. Surgery needs to be safe, and surgery needs to have, of course, we can't guarantee outcome, but we need to have a good confidence of success. So the short answer to this question is when the BMI is excessively high, neither of these criteria are met, and surgery is unlikely to be safe. In fact, surgery is going to be risky, and two, the surgery is not going to work, and we would be doing the patient a disservice. We understand where the patients are coming from. They're frequently feeling helpless. They've seen many doctors. They see us as an entity which can truly help them. So they had high hope for us. So it really pains us to have to tell them that, no, unfortunately, at this time, we cannot help you. But it is our responsibility to let them know that surgery at this time, not only that it wouldn't help them, can severely hurt them. And another thing that's frequently underemphasized in lymphedema management is that being overweight severely set the patient back in terms of lymphedema management. So particularly lower extremity lymphedema is so significantly exacerbated by being overweight. So weight loss for people who are a bit heavy really should be considered part of the mainstays of lymphedema management for both upper and lower extremity lymphedema. But especially for lower extremity lymphedema, many patients will see very noticeable improvement with significant weight loss, even with everything else being the same. And we see that all the time. So weight loss is such an important topic. I really can't do justice with just this 2-minute response. And I would encourage those of you who are interested on this topic. I know weight is a sensitive topic, but know that if you're heavy, weight loss can help you. Look into it. And I think you would be glad that you did. I will add that I read on the Lymphie Strong forum that frequently patients are quite upset when they're told by their physician or therapist that they need to lose weight. Please don't be upset. We're trying to help you. And when we tell our patients to lose weight, it's really no different from when we told them that your blood sugar is too high in preparation for your surgery. You need better control of your blood sugar, or your blood pressure is not well controlled enough, or your nutritional status is not sufficient. You need to get more protein to get boosted up in preparation for your surgery. Same thing, weight is just another health parameter that we need to observe and optimize prior to surgery for our patient's safety.
You said it way better than I did, because that surgeon told me to bump up my muscle tone. Okay. Okay, first question. How does a doctor determine if one has LE fat?
So there's scientific ways to determine, and there are also quick and easy ways to determine. We'll start with the quick and easy way. The quick and easy way is you compare yourself, pinch yourself, the affected side and the non-affected side, and the difference you see is lymphedema fat. So let's say if I have lymphedema in my right arm, I pinch my right arm fat and I pinch my left arm's fat. If the right side has 5 centimeters, the left side has 2 centimeters, that's a big discrepancy. We're not perfectly symmetrical, but we shouldn't be that asymmetrical. So the only difference is lymphedema fat. So that's the quick and easy way to determine that. Another feature of lymphedema fat is that usually it's a little bit more rigid. And as the disease progresses further, those fatty tissue become even harder. So when you pinch these differential amounts of fatty tissue, lymphedema fat tends to be harder. So an experienced clinician, just by looking at the patient and feeling the tissue quality, we can easily tell. But if you're looking for scientific ways to tell, we can get an MRI, and we do occasionally get the MRI to try to quantify, at least get a sense of the quantity of lymphedema fat that we're dealing with. This is particularly relevant in patients who have poorly controlled swelling. So sometimes we see patients with a lot of lymphedema fat, but at the same time, as a result of having a large amount of lymphedema fat, their compression therapy has become ineffective, and therefore their lymphedema fat is also filled with a lot of fluid. They're like wet sponge. They're completely soaked and engorged with fluid. So in that situation, it's hard for us to get a good sense of the quantity of lymphedema fat. That's when we would obtain an MRI. And on the MRI, we can clearly separate the fluid and the fatty tissue.
Gotcha.
And there's also bioimpedance spectroscopy, which I won't get into, but on this, we can get a breakdown of how much fluid, how much fatty tissue, how much muscle, so on and so forth.
That was the next question. Which specific tests would determine how much lymph fat is present? Next question is, how would we know if we are a candidate?
So the short answer is all lymphedema patients are surgical candidates. When we say a patient isn't a surgical candidate, we're saying the patient isn't a surgical candidate. It's not that the patient isn't a lymphedema surgery candidate. We are saying that for this patient, due to medical consideration, such as having a BMI of 50, now if this patient undergoes surgery, this patient is likely, the risk of developing a complication is very high. That's no different than saying a patient has poorly controlled diabetes, their sugars are constantly in high 100s, low 200s. That patient is not a good surgical candidate. But all lymphedema patients are candidates for surgery. So as I have consistently been saying in my lectures, that I don't consider surgery a secondary treatment. I don't require patients to fail lymphedema therapy before they consider surgery. Failed lymphedema therapy isn't a prerequisite to surgery. I consider surgery a treatment option. It's not for everybody, but I feel strongly that patients should be informed when they are diagnosed that you can choose to treat your condition with lymphedema therapy, which is highly effective. It does have a set of requirements, but there's also surgical treatment options that patients should be informed of, and which is currently, for the most part, not being done. Most patients are not informed, which is unfortunate.
I'm so glad you said that, because I see that not only in my group, but on different online forums, on the internet, where the thinking is you have to fail CDT or complex or complete decongestive therapy, or you have to be in pain or meet some, criteria in order to consider surgery. And nowadays, to your point, you just said it's an option.
So again, this is my opinion. There's certainly surgeons who do uphold those requirements, although I see conflicting practices. For example, now we are offering preventive surgery to prevent lymphedema. You probably have heard of the procedure called Lympha, which is performed at the time of lymph node dissection. So do those patients have lymphedema? Not yet. They don't have lymphedema yet. So if we are accepting preventive lymphedema procedure, what do we have to turn down patients who already have lymphedema? So I think in a way, to require patients to fail lymphedema therapy prior to offering surgery, we're conflicting ourselves. If that's the mentality, then the preventive surgery should not even be performed, because the patients don't have lymphedema yet.
Right. That clinical trial is, for those of you that are not aware, in the attendance, there's a clinical trial underway at the University of Chicago currently for the Lympha project. Next question. How does the doctor determine if a patient has LE fat in the abdomen?
The patient has lymphedema fat in the abdomen?
Yes.
So the determination of fat in the abdomen is a bit tricky, because as I mentioned before, usually we compare to the normal size. So there's a control. There's a control for comparison. And on the abdomen, there's no control. We only have one abdomen. Another factor that makes it difficult to determine is that abdomen is typically where we have a lot of fat anyway. So how do you know which portion of it is physiologic and which portion of it is lymphedema? Fortunately, okay, I'll tell you one easy way, and then I'll tell you the practical, clinically relevant way. So the easy way to find out, well, it actually may not be easy, but it's conceptually easy, is fatty tissue that's refractory to weight loss would be lymphedema fat. So if you lost 20 pounds and your abdomen is looking the same, those are lymphedema fat. So that's conceptually easy. In practice, it may be difficult for you to lose 20 pounds, but if you lost 20 pounds, your abdomen is unchanged, those are lymphedema fat. In clinical practice, in patients who suffer from abdominal swelling, it's very uncommon to see isolated abdominal swelling. The most common presentation is bilateral lower extremity lymphedema with obviously leg swelling, genitalia swelling, lower abdominal swelling. That's probably the most common presentation in patients who have abdominal swelling. And in this scenario, most frequently, we would start out by treating the leg lymphedema, because leg is much more pressing. Leg lymphedema typically progress faster because of legs being a disadvantaged position, being dependent all the time. So interesting thing, which is a good thing, is that when we start treating one leg, usually other affected parts improve. So when we start to treat one leg, the contralateral leg, the genitalia, and the abdomen improve. So then we would go on to treat the other leg. Again, every other affected parts improve. In general, we much less commonly need to directly treat the genitalia and the lower abdomen. So most frequently, we don't need to go up and treat the abdomen directly.
Next question is, this might be for Erica. How is BMI calculated?
Yes, Erica,
So
you want to take that?
essentially a mathematical formula that incorporates your height and weight. You don't need a formula necessarily. If you just Google BMI calculator, which is how a lot of people figure out their related BMI to themselves, that's the easiest way that you can find out what your BMI is.
And right now the threshold at Cleveland is 32, correct?
For Dr. Chen, it's 32.
Yeah. Okay.
That is correct.
Next question is, breast cancer surgeries and radiation have caused scar tissue in my chest, blocking lymphatic fluid from flowing and causing my chest to swell. My CLT is doing cupping, lasers, and MLD to try and break up the scar tissue. It has helped a little, but curious if there is a more permanent fix. Can surgery be done on radiated skin? That's a great question.
So, well, the good thing is that isolated lymphedema, assuming arm isn't affected, well, in this scenario, the more common presentation is we see chest swelling, axillary swelling, and arm swelling. If that's the presentation, I would suggest treating the arm first. Arm actually has worse prognosis and would need treatment even more urgently. It's much less common to see isolated chest swelling. And if that's what you have, isolated chest swelling in general has a better prognosis than arm swelling, because not just the chest, our trunk can handle swelling much better. Our trunk has a lot more accessory drainage pathways, whereas in our extremities and the arms and in our legs, they all need to drain to the trunk. So the armpit and groin are choke points. So if you have surgery or damage to the axilla or to the groin, then the arm and legs swell up. Whereas in the chest, there's a lot of drainage pathways that can drain to the top, to the side. The dominant drainage pathways is to the axilla, but there's also accessory drainage pathways going centrally, going in other directions. So in general, the prognosis is good, especially if your swelling is relatively recent instead of years out. I think sticking with your therapist, continuing therapy would be helpful. Although my recommendation would be to always know what is the severity of injury, lymphatic injury, that a patient has. Given the same presentation, all we hear is chest swelling, but is it mild injury underneath? Is it intermediate level of injury, or is it severe injury? Without imaging studies, we don't know. And of course, the prognosis would be different depending on the severity of injury. If the severity is already quite high, then we probably need to have a lower threshold of considering surgery. Whereas if the injury is quite mild, we could say that based on our experience, it's unlikely that you would ever need surgery. So getting imaging data and understanding the severity of injury is quite important. So I would recommend that.
Next question is, how does age impact surgery qualification? As I approach 65 years, I'm concerned I may be running out of time for available surgeries.
So not to worry about that in terms of considering surgery. We've operated on patients as old as, I think it was 89. So in general, these procedures are quite safe, provided that we safeguard the criteria, as we have already discussed. As long as the surgical criteria are met, these are safe surgery. I think in terms of age, it's much more relevant to consider age-related loss of lymphatic function. If you're already having lymphedema, you should know that, and if you're relatively senior, you should know that we lose lymphatic function as we age, unfortunately. And actually, like all bodily function, all physiologic functions, we decline with age. We lose bone mass, we lose muscle mass, we don't have as much stamina, and our skin relax, we develop wrinkles, so on and so forth. We lose lymphatic function with age. So if you are already having lymphedema, aging is an adverse factor. So you definitely should do things that help you preserve your lymphatic function, or at least slow down the injury to your lymphatic system. And that would be the lifestyle modification, the things that your lymphedema therapist would talk to you about. So I won't get into that here.
Okay, next question. Do you see cases in which the surgery is not effective at all? I have a normal BMI, 22, and very active, primary and left leg. Would I be a good candidate?
Again, I can't really comment on your individual case until, and it wouldn't be responsible for me to start to tell you one way or another because I haven't assessed you. But your first question, have I seen surgery not being successful? Of course. Surgery is not an exact science. And even when performed in the optimized condition in the hands of most experienced surgeon, and with the surgeon in his or her best condition, can fail. No surgery has 100% success rate. So surgery can fail. And that is one significant drawback that patients considering surgery should consider, the possibility of failure. And that's why as a surgeon, when we consider, is this surgery worthy, is it recommendable, we're not just considering how much the surgery can help you, we are also considering how much can the surgery hurt you. So in considering surgery, both the success and failure need to be considered. And if the surgery fail, how much would the surgery hurt you? How much would that set you back? So but rest assured that in general, when a surgeon recommends a procedure, in our mind, we've already done that risk-benefit calculation, and we've already weighed the benefit and risk and pros and cons. And yeah.
Okay, next question. Is there any doctor in Europe to perform LVA or any consultation in this direction? And who is the best? Well, you just kind of answered that one. Who is the best candidate for LVA? What tests do you need to be a candidate for LVA?
So there are certainly increasing numbers of doctors performing LVA in Europe. Actually, that's around the world. Actually, not too long ago, there are very few of us. There are only a handful of us around the world. But in the recent years, we've definitely seen Supermicrosurgery taking off around the world. So if you search online, if you search particularly on YouTube, during this past year, many of us have done a lot of webinars, so you can find our lectures online. And you can just search for doctors who talked about LVA a lot. And many of us would share our case volume in the lectures, so you can find those surgeons. As far as who's the best candidate for LVA, I'll share with you the traditional thought, and then I'll share with you the most recent discoveries. So the traditional belief is that LVA should only be offered to patients with early lymphedema. The recent discoveries are that that's not true. LVAs remain effective even in patients with advanced lymphedema, which is good news, but that actually makes our decision-making process more convoluted now. So now between LVA and lymph vessel transfer, how do we go about choosing between the two? That becomes convoluted because we used to be performing Patient with solid predominant lymphedema, we do liposuction. Patient with fluid predominant lymphedema, if they have early disease, we do LVA, late disease, we do lymph vessel transfer. But now we know LVA continues to work. So when do we do lymph vessel transfer? I can tell you I don't have an easy answer to that. In fact, I just wrote an expert commentary article in, I want to say, Plastic Surgery Research. I think that's the journal. It's going to come out and focusing specifically on this topic. How do we choose between these two procedures? But I can already tell you the conclusion is that it's not a black and white situation.
I probably need to create a page on the site that has all of your publishings in the various journals. That would probably be helpful to the group.
For patient trying to select surgeon, of course, my advice is be open and feel free to ask the surgeon their opinion. If they were, what do they think? Would they want to undergo the procedure they recommend if they were the patient? And feel free to ask the surgeon, how many of these have you done? Do you feel comfortable? So I think we should all be completely open with and transparent with the patient, how experienced or inexperienced we are. I do encourage even inexperienced surgeons to continue to offer these procedures because as of today, we don't have enough lymphedema surgeons. And if we are encouraging surgeons to join us in helping you, they start out inexperienced, of course. And experienced surgeons were once inexperienced. If they don't start, they will always be inexperienced.
Sure.
But also keep in mind that even for inexperienced surgeons, lymphedema surgery are some of the most complicated reconstructive microsurgery. So even inexperienced lymphedema surgeons frequently are already highly accomplished, experienced microsurgeons.
Okay, next question is, how do you distinguish between lipedema or lipedema versus obesity fat? Both thighs, butt, abdomen. Assume diet and exercise will help, but when should liposuction be considered an excess skin removal? I have venous insufficiency and pain in my thighs.
So again, I'll keep my response general. I take it that your question is, how do we determine whether this is obesity or lipedema? So lipedema is a separate condition from lymphedema. So very frequently, patients and doctors and therapists alike are confused between lymphedema, advanced lymphedema with lymphedema-induced lipodystrophy, and those with lipedema and those who are heavy. Or patient can have lipedema and lymphedema simultaneously, or the patient may have lipedema, lymphedema, and is heavy. So it certainly can cause a lot of diagnostic confusion, particularly if the provider doesn't have the capability to offer advanced imaging. Then they certainly won't have the means to differentiate one entity from another. So there are definitely ways to differentiate them, and it gets too lengthy. So it would involve use of indocyanine green lymphography, the use of bioimpedance spectroscopy, and also a careful history taking, because each condition and entity do have a different disease progression and characteristic history, and also morphology of their symptoms. So in experience, for experienced clinician, with the help of modern technology, we can differentiate these entities. But what I can tell you is, excuse me, they often overlap. And yeah.
Okay. Next comment and question is, wow, thanks a bunch. I wish more doctors would be as informed as Dr. Chen. Are there doctors on the East Coast that he can recommend?
So there are a lot of doctors I can recommend, but please forgive me to not make recommendation on the open forum because there are a lot of them. If I miss anyone, then that's not going to be good. I'm happy to, well, email me. I'm happy to send you a recommendation.
And for my part, the practice that also works with the Lymphie Strong community is the Boston Lymphatic Center, which is led by Dr. Drew Singraw. I've known Dr. Drew since 2018. Again, I've never had surgery with them, but they've done a lot to host lymphedema patient symposiums, and they're just, I just find them to be a very kind practice. So.
Well, since Varun mentioned Dr. Singhal, I certainly can second that. Dr. Singhal, definitely one of the foremost lymphedema surgeons in US, and certainly a reliable surgeon. You
can find the video with me and the entire Boston Lymphatic Center group. That YouTube video is also on my channel, just to get you started. Next one. I am not familiar with the term lymphedema fat. Does this mean the lymphedema was caused by being overweight? I have a BMI of 22 and I have never been overweight, so my lymphedema is definitely primary. But do I have lymphedema fat now because the lymphedema has progressed?
I'm going to let Erica take this one. My throat is telling me if I'm talking a little bit too much. Erica, can you take this one, please?
Yes. So lymphedema fat is a term used to describe more of a solid component of lymphedema, and your question kind of talked about that. When you have the earlier stages of lymphedema, you are more fluid predominant, but as you progress, and as we know, lymphedema being a very inflammatory disease and progressive over time if not optimized appropriately, you can then start to becoming more solid and more fibrotic over time. So when Dr. Chen mentions the lymphatic fat, it is in reference to more that solid component, but that's not to be confused with lipedema. Those are separate diseases.
Okay. Next one is regarding my chest lymphedema question you just answered. Only 2 lymph nodes were removed in each armpit. I do not have any lymphedema in my arms, only my chest. My Zoom was disconnected and now I'm back on. So I think that's a little disjointed from the first question. Let me go back to the answer. Or maybe we can save that one for last, because I think we have to go back to the first question that she had. Okay, so her next question is, I am confused. I thought lymphedema involved fluid. Lipedema or lipedema is fat. I heard you say lymphedema fat. I think you just answered that one.
Well, let me just add a bit more to Erica's answer again. So I'm glad that these questions uncovered this knowledge gap among our patients. It's important to know that lymphedema isn't just a fluid disease, and therefore even the term lymphedema is a misnomer. And the earlier thoughts, so we recognize the presence of lymphedema fat actually quite early. But the earlier thought, the earlier belief was that we don't see lymphedema-induced lipodystrophy until late in the disease course. We now know that's not true. Lymphedema fat can start early, and it's actually not black and white in that in the early phase, you have all fluid disease, and then sometime along the disease progression, all of a sudden you have lymphedema fat. Doesn't work like that. The lymphedema fat starts insidiously and gradually. So if we are careful in our examination, we can actually appreciate it fairly early on in the disease process. But in the beginning, it's quite subtle. So patient may not notice it themselves. But when we ask them, think back in your disease course, in the beginning, you always wake up with a normal looking leg or arm. Your arm or leg gets puffy by the end of the day and you go to sleep. Next morning, you wake up, it looks normal again. But somewhere along the line, that reversal, that normalization that you see every morning stops. Now in the morning, yes, your arm still looks better, but it doesn't normalize. So what is that difference? That difference right there is lymphedema fat, because fluid goes in and out quickly and easily. The fatty tissue stays. Once it's deposited, it's there. You can't compress fatty tissue away. So that loss of disease reversal or swelling reversal, that loss of reversibility is the telltale sign of lymphedema fat. Lipedema is a completely different condition. Patient can have lipedema and still have normal lymphatics. So it's a completely different condition. Lipedema is pathologic deposit, abnormal deposition of fatty tissue. It can involve lymphedema, but it doesn't necessarily need to include lymphedema.
Okay, next question. And I think these two are going to be our last two questions because we're coming up at the top of the hour. What are some of the common reasons the surgery is not effective?
So there are actually a lot of reasons, and there are many reasons that are commonly seen. I can only comment on what I have seen. What I have seen, the lymphedema surgery not worked in patients. The most common cause is inappropriate choice or operating on the wrong patient. That's the most common cause. Let's say a patient with solid predominant lymphedema in the leg, and the surgeon perform an LVA procedure. Is the patient going to have improved lymphatic drainage? Yes. Is the patient going to see a reduction in the size of the leg? No. So if the patient and the providers is determining the outcome of surgery based on the size of the leg, they're going to conclude that the surgery failed. The surgery did not work. And that would be a classic example of a great procedure, but performed in not the best patient candidate. And also they track the wrong outcome. If they perform ICG lymphography before and after the LVA procedure, they will most likely see that the lymph drainage improve. Although if the patient won't be happy unless the patient has a skinny leg, the patient is still not going to be happy. And as I said, having lots of lipodystrophy will interfere with their compression garment. So the patient will continue to require a lot of compression, and the patient won't be happy, satisfied with the surgical outcome.
I'll add my 2 cents on some of the things that I've seen over the years from what people have shared. Is sometimes a patient will admit that they did not follow or they were not compliant with the surgeon's orders. So I think that, again, I've never personally done it, but that's also an important point, is to be compliant with the post-op instructions
Definitely.
for any surgery, not just lymphedema surgery, any surgery you get.
What you just said reminded me to mention this. There sometimes surgeons may stretch the indication of a procedure because the procedure is so desirable. For example, comparing LVA to, say, lymph node transfer, LVA is so much less invasive. So sometimes we would see a patient who, based on their diagnostic workup, we're judging that their lymphatic injury is a bit too severe for LVA, but patients really strongly desire that we at least give it our best shot. So that would be a situation that we stretch the indication of the surgery. So if the patient, for LVAs constructed using healthy functioning lymphatics, those LVAs are strong LVA and they would pump regardless. For LVAs constructed using weak, damaged lymphatics, those LVA will continue to drain as long as the patient compress, providing a driving force. So patient compliance with compression following LVA procedure in those patients would determine success or failure of the LVA procedure. So I just thought of that when you mentioned about post-operative compliance.
Yeah, it doesn't happen very often, but I'll see a post that someone shares that, you know, they didn't, for whatever reason, things happen, you know. You could have an injury or whatever, may not necessarily be within the patient's control, but that's something that I've seen. Next question is, as you know, it is extremely frustrating for patients to discover their day-to-day doctors know little about LE. I've been hearing for 7 years that med students typically only receive 15 to 30 minutes of lymphatic training. Do you know how this can be changed to allow for additional lymphatic training in medical school?
So that is a myth that I have seen them propagating a lot. And so I would like to share with you that I probably also spent similar amount of time on high blood pressure, on diabetes, on arthritis. Medical school is not where we learn how to treat patients. So medical school is in preparation, is to prepare a doctor for specialty training, residency training, or fellowship training when we really learn how to care for our patients. So the med school education is meant to cover breadth. It's not meant for in-depth learning. So I wouldn't expect a typical primary care physician to know a whole lot about lymphedema, and he or she is not expected to. Just like you would go to a cardiologist if you have a heart problem, you wouldn't come to me. I may be a Supermicrosurgeon, but I can't help you with your heart disease. I can't help you if you if you have athlete's foot. I don't know which antifungal I should prescribe you. So we're in the age of specialized medicine. We all have our scope of expertise. We're not expected to be a jack of all trade. And so the saying that doctors spent 15, 20 minutes in med school on lymphedema, as if that's an indication that doctors are weak and can't help you, that's not true. And that's not accurate. Really what we should be pushing for, I agree that lymphedema patient population is underserved. Really what we should be pushing for is the science, the specialty of lymphology. Not to teach more in med school, but there needs to be a push for a specialty of lymphology or a specialty of lymphedema experts. And this won't start until insurance carriers start to properly reimburse these procedures and start to properly reimburse lymphedema therapy. start to cover your compression garments properly. So it really, again, comes down to education, and it really comes down to why we're doing this, to educate, to spread the information, to raise awareness. Ultimately, it will cause insurance company to, yeah. So I hope that alleviate your concern. Medical education is just fine. We do need more lymphedema doctors. We do need more lymphedema surgeons. We're having a hard time getting more surgeons, getting more recruiting, attracting more specialists to join us to help you. And I mean, that is a serious problem, but not the medical education.
I'm laughing because I remember last year when you called me for on a personal side, and I told you that you couldn't help me. And you said, I know how to take vital signs. Oh my goodness. That was so funny. But you're totally right. I totally understand what you're saying now. I'm gonna stop doing that because I'm guilty of saying doctors only get 30 minutes. That's an interesting perspective. Okay, next comment. And I think this will be the very last question. This has been a phenomenally informative hour. Thank you all for your time and willingness to share your knowledge. You're most welcome. And final question. Does compression prevent lymphedema from turning into the next stage of lymphedema when it becomes fibrotic?
So based on what we know so far, it's a speculative yes. So we know that for all lymphedema, there's lymphatic stasis. And whether that stasis comes from the lymphatic system being underdeveloped, so there's insufficient number of outflow pathways, conduits, or there is an injury, so there's an obstruction causing the stasis. Whatever the cause, there's lymphatic stasis, which leads to lymphatic hypertension or elevated pressure in the lymphatic system. You can think of it as high blood pressure. High blood pressure by itself causes damage to our blood vessels, which would then cause hardening of the blood vessel, which would then cause even more high blood pressure. The situation is similar here. The insufficient outflow, insufficient flow, creating this lymphatic hypertension, which then causes damage of the lymph channels, which would cause the lymph channels to lose its ability to pump, to squeeze, to push the lymph forward. So what happened when you wear your compression is you're squeezing, you're helping, you're giving your lymphatic system a hand in moving these lymph. So there's still some missing links we need to fill in, but it makes complete sense that by wearing compression garment, you're helping to improve outflow. You're helping to decompress a congested lymphatic system, and that should help slow down the disease or stop the disease progression. So I can't emphasize that enough. Compression is critically important. You need to wear a compression garment. You need to wear it to prevent swelling. Try to avoid putting your compression garment on after you have seen swelling. That's already an episode of injury to your lymphatic system. So you should wear your garment prophylactically. By now, you should know under what type of circumstance you're likely to get into trouble. The weather gets warm, you had a little bit too much salt the night before. And when you get that tingling sensation, before you even see swelling, get your garment on. Even better, you already have, knowing yourself, you already have your garment on before you get that sensation. And by the way, if you're in your garment, your arm or leg still swell, that's not a good garment. Talk to your therapist. Your garment should maintain optimal containment. That's what your garment should do. Garment fitment is extremely important. To wear a garment that fits you well is extremely important. And so these are the basics that I think all lymphedema patients should try to practice every day.
Thank you so much. Thank you, Dr. Chen. Thank you, Erica Hopkins, for joining us today from Cleveland Clinic, from the Center for Lymphedema Research. I think, I don't know about other groups, but this is the first of its kind for the platform. Like I said, we have a group that essentially asks questions 24/7, 365 days a year. And Dr. Chen often chimes in unexpectedly on various posts from different people. And this was just a way of connecting both face-to-face and more efficiently addressing all of those questions. I want to thank everyone who attended, and especially those of you who were courageous enough to share your questions. I want to close with the fact that we're just here to provide the information. None of this is medical advice, as Dr. Chen alluded to earlier in the programming. Our opinions, I may not agree with everything Dr. Chen said. He may not agree with everything that I share or post. We're just here to have a forum of discussion and information sharing where everyone can then go on and ask their own personal physician or clinician what is best for them. So thank you all. I appreciate you attending, and God bless you. Have a good one. Bye-bye.